Yes, sir. Welcome, everybody, to Cardiovascular Medicine Grand Rounds. I am very excited for today's presentation. We have a little bit of a different format. First of all, this will be the last presentation of the calendar year. We'll be resuming after the New Year's. Today, what we have are our stellar cardiology fellows giving us an overview of the key clinical trials from the American Heart Association scientific meetings. And then there's going to be some moderation and comments by Dr. Eagle. So let me introduce the speakers today. So Devang, Amin is a second-year cardiology fellow. He completed his medical degree and doctorate in biomedical engineering at Northwestern University. He then did his internal medicine residency at University of Colorado, and he enjoys traveling internationally, exploring restaurants, and hiking. Lakotah Hardie is a first-year cardiology fellow. She completed her master's in science at Montana State University and medical degree at University of Colorado. She then did her internal medicine residency at Massachusetts General Hospital in Boston. She enjoys hiking, baking, and helping her parents in the ranch. She hopes to become someday an expert antique roadshow. Heather Weed is a second-year cardiology fellow. She completed her medical degree at Central Michigan University. She then completed her internal medicine residency at Case Western Reserve University, where she also served as a chief medical resident. She's interested in electrophysiology as a career pathway. Scott Ketcham is a third-year cardiology fellow. He completed his medical degree at State University of New York at Buffalo. He then did his internal medicine residency at University of Michigan. He is passionate about cardiac critical care, and his research focuses on ways to improve care in this population. He will be joining our faculty next year with plans to then undergo critical care training. George Hanna is currently a structural fellow. He graduated from Ross University School of Medicine. He completed his internal medicine residency at Greater Danbury Community Health Center, cardiology fellowship at University of Toronto, and interventional cardiology fellowship at University of Michigan. Dr. Eagle doesn't need much introduction, but very briefly, Dr. Eagle is the Albion Hewlett Professor of Internal Medicine, Professor of Health Management and Policy, and Director of the Frankel Cardiovascular Center at the University of Michigan. He's originally from Montana. He attended Oregon State University, followed by Tufts University for medical school. He completed residency and chief residency in internal medicine at Yale. And he followed that by research and clinical fellowships in cardiology and health service research at Harvard. We were lucky to have him come at University of Michigan in 1994, where he developed an outcome research program focusing on quality, cost effectiveness, practice guidelines, acute coronary syndrome. He also founded the Project Healthy School program and the Project My Heart, Your Heart program. He has had many accolades from the American College of Cardiology. He received the Master designation in 2009 and the Distinguished Teacher Award in 2012. I could go on and on listing the list of accolades, but I have to say that Dr. Eagle is an educator at heart, a true mentor, and an example for all of us to follow. So please help me welcome them to today's webinar. Thank you.
Thanks, Dr. Moy. I'm sure I speak for all the fellows when I say that we're really excited to be doing this, and we're grateful for you guys having us here today. Without further ado, let's get into talking about some important research. The first trial that we're going to be talking about is SELECT, which was entitled Semaglutide and Cardiovascular Outcomes in Obesity Without Diabetes. So a little bit of background. As we all know, obesity is very common in our population, and we know that GLP-1 receptor agonists like semaglutide result in substantial weight loss in these folks and reduce the risk of cardiovascular events in patients with diabetes. But it remains unclear whether or not semaglutide would reduce future cardiovascular risk in overweight or obese patients who have pre-existing cardiovascular disease but do not have diabetes. And so the SELECT investigators sought to answer this question. They performed a randomized, international, multi-center, double-blinded, placebo-controlled trial of 17,000 patients who were overweight and were non-diabetic and who had established cardiovascular disease. They randomized these patients to either once weekly semaglutide 2.4 milligrams or matching placebo. The mean age of the patients was 61.6 years and 27.7% were female. 84% were white, and the mean BMI in enrollment was 33.3. 76% had a prior heart attack and 23% had prior stroke. The mean LDL in enrollment was 78. They followed patients for a mean of 40 months, and premature discontinuation of the study drug occurred in 26.7% of patients in the semaglutide group versus 23.6% of patients in the placebo group. They tested a primary outcome of a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. This outcome occurred in 6.5% of patients in the semaglutide group versus 8% of patients in the placebo group, for a hazard ratio of 0.8. And you can see on the right that the curves separate quite early. They also looked at secondary outcomes in a hierarchical confirmatory testing manner. The first of this hierarchy was death from cardiovascular causes, which occurred in 2.5% in the semaglutide group versus 3% in the placebo group. The hazard ratio was 0.85, but notably the confidence interval crossed 1, and the p-value was 0.07. Because the p-value did not meet statistical significance, they did not perform further hierarchical statistical testing, but they do note a hazard ratio for a heart failure composite endpoint favoring semaglutide at 0.82, and a hazard ratio for death for any cause of 0.81 favoring semaglutide. Here are their secondary outcomes. And in this scenario, you can kind of see the curve separate closer to about 36 months. They also reported adverse events in both groups. Serious adverse events occurred in 33.4% in semaglutide versus 36.4% in placebo. But adverse events that led to permanent discontinuation occurred in 16.6% in semaglutide versus 8.2% in placebo. And this was predominantly driven by gastrointestinal disorders. The authors concluded that once weekly subcutaneous semaglutide at a dose of 2.4 milligrams reduced the risk of a composite outcome of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke by about 20%. It seems as though this is going to be practice changing and expanding upon the indications for GLP-1 receptor agonists and an already expanding indication list. Dr. Eagle, what are your thoughts?
Mike, can you hear me all right? Okay. When's the last time we had medication that lowered mortality? But when some of our patients would say, well, what happens when I stop it? And I say, what happens when you stop taking your insulin or your blood pressure pills or your statin? So we're getting enough momentum now that these are cardiovascular drugs. Non-diabetic, LDL of 78, not BMIs of 40, 33, and this kind of effect. So there's a reason this was the lead article in the New England Journal. It's the most important file at the meeting. And I think we're going to see nothing but increasing indications for these meds as long as the safety profile holds. And this is 3.5 years. It's pretty good. So I was really impressed with this trial.
Thank you, Dr. Eagle. The next trial we'd like to talk about is MINT, which is titled Restrictive or Liberal Transfusion Strategy in Myocardial Infarction and Anemia. A little bit of background. The hemoglobin level of 7 or 8 has been widely accepted as a threshold to administer red blood cell transfusion in a lot of different clinical scenarios. However, patients experiencing acute myocardial infarction might benefit from higher hemoglobin levels for improved myocardial oxygen delivery. The investigators sought to answer the question, would patients with acute myocardial infarction and anemia benefit from a higher hemoglobin level compared to a transfusion threshold of 7 or 8? The investigators performed a randomized international multicenter trial, 3,500 adult patients with a hemoglobin of less than 10 who were experiencing myocardial infarction. They randomized patients to a liberal versus a restrictive transfusion strategy. In the liberal arm, patients received 1 unit of packed red blood cells on randomization and as needed to maintain a hemoglobin target of greater than 10. In the restrictive arm, transfusion was permitted for a hemoglobin less than 8, strongly recommended for a hemoglobin less than 7, and required for persistent angina that was refractory to pharmacotherapy, regardless of what the patient's hemoglobin level was. The population was a mean age of 72.1 years and 45.5% female. The mean hemoglobin prior to randomization was 8.6. Discontinuation of the study protocol occurred in 2.6% of the restricted group versus 13.7% in the liberal group. The types of MI experienced by patients in this trial, according to the third universal definition of MI, were 81% non-STEMI, 42% type 1 MI, which is defined as an occlusion of a coronary artery due to plaque disruption, and 56% due to a type 2 MI, which is a supply-demand mismatch. 65% of the patients had multivessel coronary artery disease, and 22% presented with acute heart failure. They looked at a primary outcome of a composite of myocardial infarction or death at 30 days. In the restrictive arm, this outcome occurred in 16.9% compared to 14.5% in the liberal strategy group, for a crude relative risk of 1.16. When they adjusted this outcome for sites and incomplete follow-up, the relative risk was 1.15 with a confidence interval that crossed 1 and a p-value of 0.07. They also looked at different secondary outcomes, and we report them here as a restrictive versus a liberal strategy. When examining all-cause death, in the restrictive arm, it occurred in 9.9% versus 8.3% in the liberal arm, for a relative risk of 1.19 and a confidence interval that crossed 1. And in recurrent MI occurred in 8.5% in the restrictive arm versus 7.2% in the liberal arm, for a relative risk of 1.19. They also looked at additional pre-specified outcomes, which I think are pretty interesting and worth exploring. When we look at the incidence of heart failure, there was really no significant difference between the restrictive and liberal arms. But when we look specifically at whether or not cardiac death occurred in each of these groups, cardiac death occurred more often in the restrictive arm at 5.5% versus 3.2% in the liberal arm, with a risk of 1.74 and a confidence interval of 1.26 to 2.40. They also looked at pre-specified subgroups and performed the primary, asking whether or not the primary outcome occurred in these subgroups, which, as a reminder, is a composite of MI or death. And in patients who experienced a type 1 MI, there was a greater risk of a composite of MI or death in patients who were in the restrictive arm. And in patients who presented with a chronic or acute heart failure or a reduced ejection fraction, again, it appears that there was a greater risk in patients who were in the liberal arm. The authors concluded that in patients with acute myocardial infarction and anemia, a liberal transfusion strategy, which was a hemoglobin target of greater than 10, was not superior to a restrictive target of hemoglobin 7 to 8 with respect to all-cause death or non-fatal MI. However, there was a non-significant trend toward increased events in the primary composite endpoint and its components in the restrictive arm. I think this trial is kind of interesting. They're looking at their primary outcome. It wasn't statistically significant, but in multiple subgroup analyses, it appears that maybe there is a benefit to treating patients to a higher hemoglobin threshold in this population. Dr. Eagle, what are your thoughts?
I was surprised by the outcome of this trial. I don't know if you were. You know, we've seen in the revascularization literature that after PCI or CABG, if you're completely revascularized, it seems unlikely that an elevated hemoglobin to 10 versus 8 is going to have a lot of difference. And there was no sub-analysis here looking at who was revascularized or not. With that caveat, in a patient with an active ischemic insult, it looks like there may be some benefit. It's not massive. It didn't change the primary endpoint. For me, it's not necessarily practice changing, but it's very interesting.
Thank you.
All right. Hello, everyone. My name is Lakotah. I'm one of the first-year cardiology fellows. And today I'll be discussing Orbita as well as the Esprit trials. So to begin, Orbita 2 was a placebo-controlled trial of percutaneous coronary intervention for stable angina. And to provide a little bit of background, Orbita 2 really built on work that had previously been published by the same group in 2018 under Orbita 1. And under that trial, it demonstrated, or the investigators argued, that patients on maximally tolerated anti-anginal therapies, those randomized to either a placebo sham procedure versus PCI, really demonstrated no benefit as regards to their exercise time and symptom management. And so the result of that was quite controversial. And it seemed to argue the natural next question, which is PCI truly non-beneficial to those patients with stable coronary artery disease and angina? Or is the result of PCI attenuated by the presence of medical therapy? And that's what the Orbita 2 trial really set out to answer. So the design of the trial is that it was a multi-center, double-blinded, randomized, placebo-controlled trial conducted across 14 different sites within the UK. In it, about 300 patients were randomized with stable known coronary artery disease, as well as symptoms of angina and demonstrated evidence of ischemia to either undergo a PCI versus a sham placebo procedure. What's notable about this trial is that investigators chose to specifically deviate from guideline recommendations as they stand now and elected to remove all anti-anginal therapies from patients in 2 weeks prior to randomization. And during that 2-week time period, patients were asked to track their symptoms on a smartphone app. Those patients that experienced at least one episode of angina were then randomized to either PCI intervention versus a placebo sham procedure. And then those same patients were then monitored for a 12-week follow-up period during which they continued to track their anginal symptoms on the same smartphone app. And at the end of that 12-week timeframe, they then return for exercise testing as well as final questionnaires. What's notable about the patient characteristics within this population that they tested is that it is represented with patients with hypertension and diabetes, but it also included those patients with multi-vessel coronary artery disease who had previously been excluded in Orbita 1. But what is also notable, I will say, is that of the multi-vessel disease, there are about 80% who are still represented by single vessel coronary artery disease. The results of Orbita 2 were significant in looking at both primary and secondary endpoints. Their primary endpoint was to assess anginal symptom scores, which with PCI demonstrated significant anginal improvement in those patients who had undergone the procedure. Secondary endpoints included their mean treadmill exercise time, which was increased by approximately 59 seconds in those who had undergone the PCI procedure versus those who had not. And then also CCS scores, which was the questionnaire that was completed at the end, were also better amongst those patients who had undergone PCI. And notably, there were no differences in the clinical outcomes or safety issues between either arms. So the investigators concluded, based on this information, that those patients with little or no anti-anginal therapy and stable angina demonstrated greater improvement in both anginal frequency and exercise tolerance when compared to those who had completed a sham procedure. And I think there are a number of clinical questions that this raises, central of which in my mind, which is how and when do we now recommend PCI to our patients with stable angina, and especially amongst those who are already maxed on anti-anginal therapies? And what do we make of the significant proportion of those patients in both Orbita 1 as well as Orbita 2 who did not experience any benefit in their symptoms from either the PCI procedure or maximal anginal therapies? And how can we best identify those patients? Dr. Eagle, I will pass to you.
Great. This is a trial that probably could only be done in the UK, right? You take your patients with chronic anti-anginal therapy and take them off. But it answers the question from Orbita 1. Was the benefit of PCI sham? And the answer is no. If you have an identified culprit lesion with ischemia on stress testing and you fix it, the frequency of angina goes down. We've known that, but after Orbita 1, it was like we had to reprove it to ourselves. Andreas Grunsig would be rolling over in his grave to see a trial to prove that PCI actually improves symptoms. But it does. Single vessel disease, low risk patients, it's a lot. It doesn't answer the question about when do we add PCI to our strategy. And that's really, I think, the patient-doctor interaction. I have several classes of medicines, Lakotah, that I can put you on that'll relieve your chest discomfort. If those don't work or you have side effects, we have another option, which is more invasive. That's assuming the stress testing does not suggest super high risk. And I think that doctor-patient relation rules the day in terms of which strategy is best and when, okay? It's a great trial.
Thank you so much. Okay, next we're going to move on to the Esprit trial. So the Esprit trial was another trial that built on prior data that had previously been published within the Sprint trial, asking whether or not tighter blood pressure control in those patients with high-risk cardiovascular disease is beneficial in the long term. So this trial, their clinical question was, what is the optimal blood pressure target? Should we be shooting for a systolic blood pressure closer to 120, or is 140 still a permissible target, especially in those patients represented by higher risk cardiovascular disease? So this trial, again, was a randomized parallel blinded trial. It occurred at 116 sites across China. In it, patients were included if they were over the age of 50 years old, if their blood pressure ranged between 130 to 180 systolic. And then they also identified patients that they declared as increased cardiovascular risk as defined by established coronary vascular artery disease or 2 or more cardiovascular risk factors. In it, approximately 11,000 patients were randomized to either the tighter blood pressure control at 120 versus the standard blood pressure control, which they identified as around 140. Duration of follow-up for this trial was approximately 3.4 years, so quite a long time. Included in this population as compared to the prior Sprint trial was a large proportion of patients with diabetes as well as stroke. The results of this trial also used a composite endpoint of MI, coronary, and non-coronary vascularization, hospitalization, or emergency visits for heart failure, stroke, or cardiovascular death. And it did demonstrate that those under tighter control had decreased risk. The same was also true for their secondary outcomes, where they measured cardiovascular death. In it, they also argued that those under tighter control had a benefit in the long term compared to those with more liberal control. However, adverse events, including serious adverse events occurring approximately 42% of patients in each group, and the most significant of which being syncope, which was much higher in those with tighter blood pressure control versus the more liberal targets. Emergency visits as well as serious adverse events related to the syncope were also increased in those with a tighter blood pressure control at the 120 target versus the 140. The conclusions of this trial argued that in an Asian population with hypertension, including those with diabetes and stroke, tighter blood pressure control at a target of 120 systolic resulted in the overall reduction of MACE. However, that was associated with increased risk of syncope. Dr. Eagle, I'll pass to you.
Obviously, the societal implications of trying to get people to a blood pressure below 120 are massive, aren't they? And I think in particular, our patients who have low diastolic pressures, particularly the elderly, this probably doesn't apply. Because if they start out with a diastolic pressure of 55, and you take them to 48, and they pass out and break a hip, they have a 1-year mortality of 50%. I do think it opens the door for the notion. We've been calling 120 to 130 pre-hypertension. And there may be high-risk patients in our practices where we want to try to go lower. It's not generalizable to the US population. So I think we have to take it with that grain of salt. But it is, and of course, there's a lot of salt in China, right? The Chinese menu has lots of salt. But it is interesting, and we need another trial, I think, proving it before we think about going down this path. Thanks.
Hello, everyone. My name is Heather. Excuse me. And today I'll be talking to you about the trial Aresia, or apixaban for stroke prevention and subclinical atrial fibrillation. And I think I would be remiss about talking about this trial if I didn't include its kind of sister trial, Noah-Afnet 6, that was presented earlier this fall at the European Society of Cardiology, that was entitled Anticoagulation with Edoxaban in Patients with Atrial High Rate Episodes. And really, these two trials blossom out of the fact that we know that atrial fibrillation often presents initially with stroke, and that obviously has significant morbidity and mortality for our patients. And nowadays, we are able to screen for atrial fibrillation much earlier, whether that be through implantable cardiac devices, ICDs or pacemakers, or ordering more Zio patches or ICDs, or your typical person who walks around with a smartwatch and has AFib algorithms that can detect atrial fibrillation. And really the thought process is if we're able to detect atrial fibrillation earlier and perhaps at shorter durations, are we able to get patients on anticoagulation earlier and therefore mitigate the risk of stroke? So Aresia looked at a specific population of subclinical atrial fibrillation that was defined as patients who were asymptomatic and had short-lasting episodes of atrial fibrillation, which I'll define in a moment, that was detected with the use of these long-term cardiac implantable devices. And we know that this is important because in patients with clinical atrial fibrillation, they have about a 2 to 3% risk of stroke per year. But it's also been found that even patients who present with subclinical, these short durations of atrial fibrillation, have about an absolute risk of 1% per year of stroke. And the overall increased risk of ischemic stroke and systemic embolism is increased by a factor of 2.5. So the study authors sought to answer the question of, does apixaban compared with aspirin lower the risk of stroke or systemic embolism with an acceptable bleeding risk, as we know these agents can cause in patients with subclinical atrial fibrillation? This was a multi-center, double-blind, double-dummy trial with enrollment over 247 sites across Europe and North America. Patients were included if they had this definition of subclinical atrial fibrillation, which in this trial was any episode of atrial fibrillation lasting more than 6 minutes, but less than that 24-hour cutoff, which is brought them into the clinical atrial fibrillation group. Patients were at a moderate risk of stroke with a CHADS-2 VAS score of at least 3, and they were greater than age 55 years. They were excluded if they had a history of clinical atrial fibrillation, and if at any point during the trial they went into atrial fibrillation for more than 24 hours, they were transitioned to open label apixaban. They were also excluded if they had an alternative indication for anticoagulation or a history of major bleed in the preceding 6 months. There was also a cutoff of creatinine clearance less than 25, and if at any point during the trial their creatinine clearance dipped below that, they were taken off the trial drug. The primary efficacy outcome for this trial was a composite of stroke and systemic embolism, and the data was analyzed on an intention to treat basis. And the primary safety outcome was major bleeding as defined by the International Society on Thrombosis and Hemostasis. In the design for this trial, there was planned formal interim analyses after 1/3 and 2/3 of the events occurred. However, the study was terminated early due to slow enrollment. This did take place throughout the COVID pandemic, as well as low event rates. As a result, more than 4,000 patients were recruited with equal enrollment between the apixaban and aspirin group. The average age was about 77, 36% were female, and 94% were white. Patients had an average CHADS-2 VAS score of about 4, and at the time that the trial was terminated, the mean follow-up was about 3.5 years in the intention to treat and 2.5 years in the on-treatment analysis. In reviewing the results, we can focus first on this lower left-hand corner where we see our Kaplan-Meier curve with pretty early separation of the apixaban and aspirin arms with a decrease in the primary outcome in the apixaban arm and a hazard ratio of 0.63. But looking a little bit closely at these results in the upper right-hand table, we know that this apixaban group was shown to have a significantly decreased ischemic stroke rate. And looking even more closely, judging the severity of the scores by the modified Rankin score, where a higher score actually signifies disabling or fatal stroke by 3.6, there was a significant reduction in disabling or fatal stroke in the apixaban group. Obviously, we want to know, is this worth the risk based on our primary safety outcome? And we'll come to those results here. This was the on-treatment analysis, and apixaban was associated with an increased risk of major bleeding with a hazard ratio of 1.8. I will point out that most of this was led by GI bleeding, which we know apixaban has been associated with. Again, looking a little bit more closely at the data, the vast majority of the patients who did have major bleeding were able to be managed with conservative measures and supportive care, such as a transfusion, but again, doesn't eliminate the fact that patients did have a significant increase in that bleeding. There were limitations to this trial. As I mentioned, 94% of the population was white, so we know this may not be generalizable to the larger population. And overall, there was a low event rate. The assumed risk for this design was 2.75% risk of stroke, and only about 1% of patients ended up having stroke. Also, note of this is this only tests apixaban, so we don't know generalizability to other anticoagulation agents. What we can conclude from this trial is that in patients who have these cardiac implantable devices, who have detectable subclinical atrial fibrillation and risk factors for stroke based on their CHADS-2 VAS score, apixaban can significantly lower the risk of stroke and systemic embolism compared to aspirin, with the greatest effect on these disabling or fatal strokes. However, we have to remember that apixaban is associated with this increased risk of major bleeding, even though patients were relatively controlled with conservative measures. At this time, I just want to bring in the results of the Noah-Afnet trial, because I think we have now 2 large trials that kind of help us answer this question about subclinical atrial fibrillation. There were some differences. In Noah-Afnet used edoxaban, and it was placebo, not aspirin, although 54% of the patient was on open label aspirin. The primary efficacy and safety outcomes were slightly different, with the primary efficacy outcome including cardiovascular death, and the primary safety outcome including death from any cause. This trial was terminated early as well due to harm and futility. And if you look at this main figure here on the right, in the upper hand corner, we see that there is no significant difference in the primary efficacy outcome, but we do have a significant increase in major bleeding in the edoxaban group with a hazard ratio of 1.3. And I want to also bring up the fact that low event rates also occurred in this group as well and was part of the reason to terminate the trial. And really there was a lack of power to measure the true estimate of the edoxaban's effect on stroke. So kind of just wrapping up these differences here, we had different primary efficacy outcomes, and it's estimated that perhaps inclusion of cardiovascular death in the Noah-Afnet group really did dilute the true effect that we saw. But also with the use of aspirin in the Aresia group, we know that aspirin can be associated with bleeding, and so it may have also reduced the difference that we saw in the primary safety outcome. I think the big picture that we can take away from these two trials is that overall risk of patients presenting with stroke with subclinical atrial fibrillation is relatively low, but it's not zero. And therefore, I think that this comes down to the fact that we need to have that shared decision-making and discuss really on a patient-by-patient basis what our desire would be to treat with anticoagulation, weighing both their chance to vast stroke risk with their increased risk of bleeding. Dr. Eagle, I'd love to hear your thoughts.
Yeah, wonderfully done. Greta, great summary, isn't it? I was surprised by the fact that cerebral bleeding is similar between aspirin and apixaban. So any of us who thought that aspirin was safer in the brain, we should not be reassured. But contrary-wise, it wasn't as safe with the GI tract. And you'll see the new ACC guidelines for AFib came out just last week. Go to acc.org. Tom Crawford described the top 10 key points of that. And the guideline authors knew about these studies because they divided subclinical into the less than 5 minutes, 5 minutes to 24 hours, and greater than 24 hours as risk groups. And I think, Heather, you're absolutely right that in those really high-risk group patients who have somewhere in the 12, 18-hour range, it's, again, the doctor-patient decision. Do I think the risk of ischemic stroke outweighs the risk of GI bleeding, and do we want to give it a try? And you know, this is an early science with digital technology, and our own Jessie Golbus is pushing the boundaries of this, and we look forward to her research going forward. Great summary.
All right, for our next trial, we'll review VERVE 101. So this trial comes on the heels of a primate study which looked at gene editing of PCSK9 using a CRISPR-based method in order to target LDL reduction. So to go over CRISPR-Cas9 briefly, for those that are not familiar, this was initially pioneered by the groups of Doudna and Charpentier, winning the Nobel Prize in Chemistry in 2020. This particular study does not use the Cas9 portion of this, but the principle is the same. Essentially, a guide RNA is created, and one portion of that RNA will hybridize to part of the DNA of interest in the gene. And then with essentially genetic scissors, this gene can be cut. And if interested, a template can be provided for repair. In this particular case, there was no template provided for repair, but PCSK9 genes were targeted. So the question that the study had was, can a single infusion of gene editing therapy reduce LDL-C in patients with heterozygous familial hypercholesterolemia? And this was purely a phase 1b study. Heterozygous FH has a 1 in 200 prevalence in the US, and it carries with it a 20-fold greater risk of ASCVD compared to the general population. In the primate study that was published early 2023, in a dose-dependent fashion, it had been found that PCSK9 protein could be reduced by 83% in these animals. And LDL-C was reduced by about 69% at most. There was a transient LFT rise as well in those animals that lasted less than 14 days, and no germline editing occurred. That is, the editing predominantly occurred within the liver. The methods of this phase 1b study were as follows. So it was a company-sponsored trial. It looked at heterozygous FH patients exclusively. The intervention was an IV injection of liposome nanoparticles, which contained the editing molecular machinery. So it contained an adenine base editor and the guide RNA targeting the PCSK9 gene. dexamethasone and antihistamine were used as pre-medication. 4 different dose cohorts were evaluated. 2 of them were known to be below the therapeutic range and 2 would be at the therapeutic range or above. 9 participants were at 20 to 8 days post follow-up. 7 males, 2 females, 8 white patients and 1 Asian patient were included in the study. The mean age was 54, mean LDL cholesterol was 201. The majority of these patients, which were quite sick, did have some pre-existing severe CAD. Many of them did have revascularization as well. They were additionally on maximally tolerated LDL therapy in the form of statins in general. None of them were taking PCSK9 inhibitors. The results of this observational study were that LDL cholesterols did get reduced between 39 and 55% in the dose arms that were expected to be therapeutic. The PCSK9 protein, as expected, did also get reduced between 47 and 84%. And there was a persistence of this LDL cholesterol reduction at 6 months in the patient that was that far out from injection. Unfortunately, 2 serious adverse cardiovascular events occurred. There were 2 MIs that occurred in this study. 1 patient actually had a death 5 weeks after receiving a dose of this drug, and that was in the setting of an MI. Another patient had a non-fatal MI 1 day after receiving the drug. Based on the safety committee, the phase 2 portion of the trial would be allowed to continue. It was thought that the first death was expected for a patient with existing severe CAD, and it was thought that the second patient did not inform the committee of chest pain prior to enrollment. Brief flu-like symptoms did occur and temporary LFT elevations occurred. The conclusions here, although we have demonstrated that gene editing here is a mechanism by which PCSK9 and LDL can be reduced, there are very significant safety concerns raised here in this new technology that has not been studied very well. 2 of 9 patients had MIs and 1 death occurred. So I think I would want more data before recommending this in the future. And the FDA agrees they would want any gene editing technology to be evaluated for 14 years during the study period. However, it is the first in-human gene editing approach for hyperlipidemia therapy. Additionally, my other question is, how will patient-centered outcomes compare to existing therapies in the form of alirocumab, for example, which we know is quite effective in addition to statins? Dr. Eagle, what do you think?
Yeah, so maybe David would want to comment on CRISPR. So CRISPR has been around for about a decade. This was one of the leading centers in the world in gene therapy soon after the genome was sequenced and delivering, genetic material in adenoviruses. Obviously, we encountered problems, including some deaths. There was a death at Penn from gene therapy, and it's gotten a lot of press in a negative way. But CRISPR technology offers a whole new possibility, doesn't it? But obviously, for those 2 deaths really stand out. Are they accidents or are they real? David, do you have any thoughts about CRISPR?
So, I mean, the technology is here to stay. Yeah, I think Jesse Gelsinger died in Pennsylvania years ago, maybe before some of you were even born, in a trial of gene therapy, one of the first at University of Pennsylvania, and it created a huge brouhaha, and the field just sort of stopped. I sit on the data safety monitoring board for another trial, not gene editing, but it's very hard for a DSMB perspective to say what's related and what's not related. And what I hear and see here is some hand waving after the fact. Oh, well, the patient didn't say they had chest pain, should not have been entered. But that's after the fact. So I think there's real risk, and I think this is a definite setback to the approach. It's an off-target effect. I think the use is going to be in single gene diseases. So familial hypercholesterolemia would be such a gene, but I think sickle cell is where we're going to have our most success in altering the genetic composition of one amino acid.
But this is a cautionary tale of off-target effects, and I think it's going to set the field back.
Great. Thanks, David. Nice summary. Beautifully done.
Good afternoon, everyone. My name is George Hanna, one of the structural fellows here at U of M. Thank you for the opportunity to present. First trial that I'll talk about is Dapa-Mi. Pretty large trial that was getting a lot of buzz before being presented. Better now? So just a quick background about SGLT2 inhibitors. We've been very lucky in the field, and our patients have been very lucky in the field over the last few years to have some trials published with great results. And SGLT2 inhibitors have actually shown reduction in mortality in several patient populations. Just some of the trials here in patients with HFrEF and even reduction in heart failure hospitalizations in patients with HFpEF. And that's across different medications in the SGLT2 family. So the question that the investigators sought to ask for Dapa-Mi was, in patients without a known history of diabetes or chronic heart failure, again, in these patient populations, we've seen a benefit. So in patients without diabetes and known heart failure that present with an acute MI and LV dysfunction less than 50%, does the addition of dapagliflozin improve cardiovascular and cardiometabolic outcomes? So this is a registry-based trial, mainly out from Sweetheart and MINAP. It was a double-blinded randomized control trial, and the investigator randomized patients to initiation of dapagliflozin versus standard care. And the primary outcome was a composite of death, heart failure hospitalization, non-fatal MI, AFib flutter, type 2 diabetes, NYHA functional class during the last visit, and a body weight decrease of 5%, also at the last visit. Now, initially, the trial investigators had designed the trial to be an event-driven trial. And I guess luckily, there weren't that many events. So the investigators, again, being blinded, they decided to change the approach to analysis from an event-driven trial to a win ratio analysis, which we're seeing more and more, at least in some of the structural trials. The inclusion criteria for the patients were STEMI or NSTEMI within 10 days, impaired LV systolic function or QAVMI, and they had to be hemodynamically stable. Patients were excluded if they had a known history of type 1 or type 2 diabetes or chronic symptomatic heart failure with a previous heart failure hospitalization within the last year and a known EF less than 40%. They were also excluded if they had a GFR less than 20. The patients that were investigated, around 4,000 patients were enrolled and followed up for 2 years. The mean patient age was 63 years old, and a fifth were female. 72% of the patients enrolled in the trial did have an initial presentation for an ST elevation MI. Again, their baseline A1C was 5.7. And the majority of patients actually had significantly reduced EF less than 50. I know that was part of the enrollment, but 30% of patients had, 6.5% of patients had an ejection fraction less than 30%, and 67 had between 30 and 49% normal kidney function. And the majority of patients were on good medical therapy with ACE inhibition or ARBs and beta blockers. The results, again, just to remind everyone of the endpoint, it was a hierarchical composite of death, heart failure hospitalization, non-fatal MI, fib flutter, type 2 diabetes, or NYHA class, and a weight decrease more than 5%. So the win ratio was 1.34, which is significant and in favor of initiation of dapagliflozin. However, when the primary endpoint, when the win ratio is calculated without weight loss and also without a new diagnosis of type 2 diabetes, there really wasn't any significance, a difference in the results between the dapagliflozin group and the standard of care group. And again, just a pictorial representation. So again, the hierarchical of all seven components, which included a weight loss of more than 5% and new onset diabetes. When both weight loss and type 2 diabetes were taken away, the results were not significant and maybe not as exciting compared to some of the other SGLT2 inhibitors, because we, had come to expect, harder endpoints, but still some benefit. So the investigators concluded that in patients with acute MI without a history of type 2 diabetes, or chronic heart failure, initiation of dapagliflozin, they did have better cardiometabolic outcomes compared with placebo. They were less likely to develop diabetes. Kind of makes sense, right? We're giving a diabetic medication. And they experienced a weight loss of 1.65 kilograms over 2 years of follow-up. When those results were taken away, again, no significant difference. The caveat, again, we have seen significant heart failure hospitalization reduction and mortality improvement in patients with reduced EF. And although these patients, 3/4 of them did have a reduced LV function in the acute setting, no significant results were noted. Again, this could be due to myocardial stunning in the setting of ischemia. Some take-home points based on the trial in ACS, the cardiovascular benefits of dapagliflozin seem limited, mainly limited to cardiometabolic effects as weight loss and new onset diabetes. What do you think, Dr. Devang?
Nicely summarized. Of course, anytime we see a trial where they change the way they're measuring endpoints midway, things aren't going well. And so we got to figure out a way to count things better to get to a statistical endpoint, which they did. And the endpoint they got to is one we already know. And that is that these drugs are useful for patients who are pre-diabetic or diabetic. And there's marginal weight loss, of not anything like the GLP-1 agonists, of course. And I think you summarized that perfectly. Thanks.
Second trial I'd like to review is the Areas-HM3 or HeartMate-3 trial, which is aspirin and hemocompatibility events with a left ventricular assist device in advanced heart failure. So as we know, LVADs or left ventricular assist devices definitely enhance the quality of life for our patients with end-stage heart failure and actually extend the duration of life in these patients. However, it comes at a cost, right? A lot of these patients we see here in the hospital and in the outpatient setting do have quite a bit of kind of non-surgical bleeding events, as they traditionally have been on warfarin and additional antiplatelet agents. So the investigators, and currently, at least with the older devices, aspirin as an antiplatelet agent was mandated with vitamin K antagonists in patients with continuous flow LVADs. And that was mainly, in terms of practice, that was mainly driven by a few smaller trials that showed in patients with LVAD, they had a higher prevalence, higher incidence of stroke. So that's why patients now tend to be on warfarin and aspirin. So the investigators sought to ask that in patients with a fully magnetically elevated continuous flow LVAD, the HeartMate-3, is excluding aspirin as part of the antithrombotic regimen safe, and how does it affect bleeding and thrombosis? So again, an international double-blinded placebo-controlled trial looking at vitamin K antagonist plus aspirin versus vitamin K antagonist plus placebo. And the primary outcome was survival free from non-surgical hemocompatibility events, and that included stroke, pump thrombosis, major bleeding, or arterial thromboembolism 14 days past the implant. The secondary outcome was a comparison of non-surgical bleeding rates. Patients were included if they were over 18 years old and they had their first durable LVAD implanted, and of course for an approved indication. Patients were excluded if they have previously, if they had previous MCS or temporary MCS, or if they had alternative indications or contraindications for antiplatelet therapy. They were unable to take oral meds through the first 7 days, or if they have aspirin allergies. Overall, pretty similar breakdown between the patient characteristics. The mean age of patients was 57 to 58. A quarter of the patients were women, and a third of the patients had an ischemic etiology of their heart failure. So the primary endpoint, survival free from non-surgical hemocompatibility related events. And again, that's stroke, pump thrombosis, arterial thromboembolism, major bleeding, 14 days past implant. Patients that were in the placebo group had longer event-free survival, 72.4 versus 68.1 events per 100 patient years. And again, this was a non-inferiority trial. And the difference between the groups, as expected, was mainly driven by bleeding events in the placebo group. So a reduction of bleeding events in patients that were on vitamin K antagonists only without aspirin. Secondary outcomes of non-surgical bleeding. As mentioned earlier, patients that were on vitamin K antagonists and placebo had lower bleeding, 25.9 versus 39.5. And that was statistically significant, and also had lower GI bleeds, 13.1 versus 24.6, with a hazard ratio of 0.61. There was no difference in stroke between both groups. Again, showing event-free timeline where patients that were on aspirin and warfarin had higher events, and patients in placebo had lower bleeding. So to conclude, antithrombotic therapy following LVAD implantation has conventionally included both aspirin and vitamin K antagonists to reduce the risk of stroke. In this trial, with the fully magnetic continuous flow Hardie 3, patients that were on vitamin K antagonists alone without aspirin had non-inferiority in terms of hemocompatibility events, mainly driven by bleeding, and up to 1 year post-implantation. Take-home point for me, based on this trial, even though it was a small trial, I think it's actually practice-changing for patients that are going to get new devices, and it provides the first randomized data that may support an aspirin-sparing regimen in patients with this Hardie LVAD 3, mainly for a reduction of bleeding.
Great summary, and a pretty big trial in a population that's hard to study. I was reassured that the signal for stroke also favored placebo, which really I think is reassuring. There was no even little signal toward higher risk of stroke if you omitted aspirin. And I'm not one of our heart failure faculty, but for me, this certainly in a high-risk bleeding patient would say, I don't think I need aspirin anymore. And maybe that's the standard now. Some people might say I need a confirmatory trial, but it was a really important study. Do you want me to wrap up?
Thank you.
So let me just say that our fellows are masterful teachers. They have been doing this wrap up of the big meetings now for a year. I think we've done 3, and they're posted on acc.org. They're widely viewed. Fellow to fellow teaching and Michigan are synonymous now. Marty Tam leads the fellow to fellow teaching conference at Hart House. Our fellows are doing the visual abstracts for the large meetings now. We just have magnificent fellows, and they're presenting their skills and education to an international audience now. So this is just a shout out to the 5 of you for a masterful job, and our whole fellowship class that continues to just shine. So kudos to you. Congrats. Victor, thank you for allowing them to shine this way, and I hope you'll invite them back soon. Okay, great. Have a great day, B.